Everyone. So this is our 9th webinar, the Health Research from Home program. My name's Will Dixon. I'm the lead investigator for Health Research from Home. I'm a professor of digital epidemiology here at the University of Manchester and a consultant rheumatologist at Salford Royal Hospital. And I'm co-hosting this with Coral, who's the project administrator for Health Research from Home. For those of you who are coming for the first time, Health Research from Home is an MRC-funded partnership grant that's aiming to bring together the community interested in the use of smartphones and wearables for population health research. We host a whole series of different events. You'll hear about some of them at the end in our announcement section, and other activities, including driver projects to learn how we join together patient-generated data with other data sources, which is very relevant for today's webinar as well. So what we're going to cover today, we'll do a bit of housekeeping in a second. Then we're going to hear from two speakers about smart health. We're going to hear from Tim Chico and then Ellen Buckley. There'll be 10 minutes to do question and answers after the two talks. Then we're going to hear an update about one of the two driver projects within the program. We serially come back and show you progress about these two studies as they make progress over the course of the 3-year period, showing you what we're learning along the way, and then we'll end with some announcements. But for housekeeping, we're recording the webinar. The recording will be paused during the Q&A session, so you'll feel free to talk openly during that. And at the end, we're going to upload that to our YouTube channel. It's also available on HDR UK's Futures platform, and we'll share the links for the recording afterwards. As you listen to the two talks, please do put your thoughts, questions, and comments into the Q&A box. We'll then address those at the end of the two talks, but drop them in as you think about them. In this Zoom webinar, everyone's mics have been muted for the presentation, but if you have questions, we might ask you to unmute. We'll unmute you and turn your camera on, and then we can see you and make it a bit more personable. And feel free to use the chat box to interact with each other and to ask us for any technical support as we go through. So it's my real pleasure to introduce the first of our two speakers, Tim Chico. Tim's a professor of cardiovascular medicine just across the Pennines from us in Sheffield and a consultant cardiologist in Sheffield too. So Tim, I'll hand over to you. Thank you very much.
Thanks so much, Will. Thank you very much for the invitation to speak. Have my slides come up now?
Yeah, we've got them. Thanks, Tim.
Fantastic. Thank you. So yeah, I'm very excited to talk to you about our project, which hasn't started yet, which means that your comments and questions and feedback will allow us to make it even better when we start recruiting towards the end of the year. I want to stress that this is not just my work, it's work of lots of people, most particularly Jackie MacArthur, who's on the call, and Ellen Buckley, who's speaking afterwards. So Ellen, I'm sorry to take the credit for a lot of work that isn't mine. So I'm not going to talk too much about the background because this audience is very familiar with the fact that we're all, certainly 90% of the population, wearing or using devices generating data, which has the strong potential to really improve our health and healthcare in general. But I've really stressed this might. I've really stressed this might because actually it's surprising how much this idea that healthcare will definitely be improved by wearable data has permeated into lots of conversations outside of medicine and science. I think there's a recognition that we really need to accelerate funding for research in this area. You'll be, many of you, familiar with this call that's just come out from NIHR about tackling a really important issue, which is the inequalities in experience of healthcare and cardiovascular disease, and very little specific focus is suggested, but wearables do feature in this. But this is at least research. This isn't an assumption that it will work. The government is clearly focusing on the potential of these technologies. The 10-year plan comes out tomorrow. And would anyone like to bet that wearables will not be mentioned in the 10-year plan? I'd be very happy to take that bet. But even in the absence of clear evidence, we are seeing things like the Tony Blair Institute suggesting that all adults should be given a wearable. This isn't actually true, but it was certainly released in the conventional newspapers that Wes Streeting was planning to give all adults wearables. And I suppose almost as a sign of the lack of evidence in this case, even the Make America Healthy Again movement is talking about giving wearables out as part of their campaign. It really is. I mean, I'm an enthusiast for this, but we have little evidence to justify this kind of implementation. So we really do need to, as quickly as possible, confirm or refute the hypothesis that data from smartphones and wearables can lead to better health and better healthcare of the people that use them. Otherwise, this money will be wasted and all that potentially lost. So Smart Health intends to help researchers like those as part of this consortium and wider begin to understand how data from smartphones and wearables could improve health and healthcare, and indeed how it could not. There will definitely be some circumstances where this data improves health, and there'll be definitely some other circumstances where it turns out that it doesn't. We just don't know what they are at the moment. And this is what we are intending to try and help support. This comes from work that Jackie and others led 3 years ago now, because what we really lack is a large-scale, accessible collection of data from wearables, but also smartphones. And crucially, that needs to be linked to healthcare data. Clearly, Fitbit, to take an example, have access to millions of people's Fitbit data, but they don't have any information on those people's health in order to correlate with, to detect the patterns that predict disease, that help diagnosis, etc. So it's the two things we need, the smartphone and wearable data, and it needs to be linked to the healthcare data. So that is what the workshop suggested was required. And in the 3 years since, I think we've just spent a reasonable amount of time discovering more and more barriers or issues to be resolved between saying that's what we need and having it. And just to pick a few, clearly there's governance implications. We actually have to say what data we're talking about in order to get the necessary approvals. We need to work out how to collect it. We need to say who's the data going to come from. We need to say where it's going to be stored and how it's processed. We need to say what healthcare data it's linked to and how it will be linked to that. We have to say how it's made accessible whilst being secure. We have to say how we're going to analyze it. And pretty crucially, we have to say how we're going to fund it. And I'm not going to tell you the answers to all those questions, but I'm going to show you how we're beginning to slowly crawl over some of these barriers. So what I'm describing is intended to be an infrastructure which will provide two services to researchers. The first is the ability to collect smartphone and wearable data. In order to clarify whether this is acceptable and what data we should be collecting, Jackie MacArthur and I from the BHF Data Science Centre did a range of consultations with patients and the public and also researchers to try and understand, okay, well, what data do researchers want and what would they use that for? And what types of data would patients and the public find accessible to collect? Clearly, there are dozens of different types of data that these technologies provide, but some are more acceptable than others. And when we did this survey, we mapped the acceptability to patients and the public, that's along the x-axis of the different types of data, and we ranked them according to the importance that researchers placed on those data. And what you can see in the top right-hand quadrant are the data types, and I should stress that this is for cardiovascular research because it was led by the British Heart Foundation Data Science Centre. Things like continuous heart rate were at the top. Researchers found them most useful and patients and the public, i.e. potential participants, found it most acceptable. But then measures of activity were also in that upper quadrant. So this was giving us a guide as to what people might allow us to collect from them, given that this is going to be a consented research study. So we have committed to an initial data set of the most high priority data types. So what we are going to start collecting in the first phase, so we will be adding later functions according to PPIE and researcher input. From a phone, we think the most useful data we can get are people's steps, measures of physical activity, but also their GPS data. GPS data, because although it's obviously very sensitive, it also gives us measures of mobility, which was in the upper right-hand quadrant. And it gives us the ability to map to measures of environmental exposures, which I think is really important if we're going to address things like inequalities and the impacts of climate. When we talk about connected wearables, that allows us to get steps as well, probably slightly more accurately, but also heart rate and sleep and some GPS measures. So when I talk about smartphone and wearable data, in this first phase of what we do, it's these types of data. So we now have ethics approval to recruit any UK adult who uses a smartphone and has an email address and is able to speak English. And we are intending to recruit 10,000 people over the next 2 years. We had, I think, a very justifiable telling off from our advisory board and our PPIE groups about the specification that people had to speak English. Now, there was some justification for that in terms of governance compliance, but I completely accept that that's not desirable, and we're aiming to expand to non-English speakers as soon as we can achieve that. And we will recruit in 3 broad groups. The first is in going out to community groups, particularly that represent underrepresented or underserved communities in research and healthcare generally. And we're planning to fund researchers in residence within these community groups to help recruit participants, but also to help inform the types of research that is performed. But we'll also recruit from NHS services in order to recruit particular types of research of patient groups that we can address specific research questions with. But then we will open this to the whole general public so that anyone who wishes can join up. People do not need to have an interaction with a researcher, so they can just see a leaflet, hear an interview on the radio, perhaps see an advert on the back of the bus, and then sign up. But there is the potential for face-to-face recruitment in clinics or communities. Just last week, we were adopted to the NHR portfolio, which means that this helps a lot in terms of recruiting from NHS services because hospitals receive some form of financial incentive for recruiting to studies on the portfolio. But whatever you route to access is, whether it's just from the community or from a hospital, it all comes to a single point of contact, which is the person has to read the participant information sheet and complete a consent form online. Now, the wording of the consent form is really important. We spent a lot of time working on that with colleagues. Obviously, it's quite a long consent form, but there's 2 clauses that I want to stress. This is our attempt to create a future-proof consent text which allows us to link smartphone and wearable data to all of someone's health care, as in NHS, and health-related data from multiple different data custodians. And as it currently stands, we believe that this will allow us to continue to collect someone's healthcare and health-related data for their entire lifetime and link it to their smartphone and wearable data. Also, it allows us to allow access to that data to researchers from other organisations, including other universities and commercial partners for research that's approved by us. I'll explain a bit more about that in a second. So once the person's given consent, they need to give us some identifiable information so that we can achieve that linkage. These don't get hung up on the forms. These are just placeholders. And then they complete a baseline questionnaire so that we understand more about someone's educational level, their employment, their demographics, And then they complete a baseline health self-report questionnaire. So I'm going to show you all the conditions that we're currently asking people about so that you can tell us to add ones that you're interested in, because later on it'll be so much easier to do analyses on this if we can pick people up who say, okay, I've got lupus, or I've got rheumatoid arthritis, or I've got a pacemaker in, and then we can identify those people at the start rather than trying to find it retrospectively. So we're asking about these respiratory conditions. Feel free to suggest more. And by the way, by the end of the talk, I'll show you how to feed back into this to refine it to your needs. Some endocrine problems, mental health issues, and we're very keen that we don't overlook the need to address issues with mental health and put that on the same parity of esteem as physical health conditions. Musculoskeletal conditions, and I'm keen to get some more suggestions from Will and colleagues. As you might expect, there's quite a lot of cardiovascular conditions and digestive conditions, and then some others. So obviously we don't want to overburden people too much. As they go through this baseline, they will tick yes, no, and how long they've had the condition. Once we have this baseline questionnaire, they will get the app. This is just an illustration. This is being built as we speak to collect that data. And then every 3 months, they will complete a change in status questionnaire, which is an EQ5D, and any new medical conditions, any change in employment and other issues. So that's the first service, which is actually collecting the data. Now, once we have the data, we will provide the service of data access to researchers. Because our ethics approval is as a research database, not as a specific research study. So we have a generic ethics approval, which then means that researchers can apply to use the data for a specific research project, and we will approve those if they fulfill the criteria without it needing to go to a separate ethics review. So the process will be fairly, as you would expect. We don't have any data yet, so there's no point applying, but I will explain in a second how you can influence that. So once we do have the data, that's GPS location data, sleep, heart rate, physical activity, and questionnaires, that will come into our secure data service, where we will clean it and process it and de-identify it as necessary, and then generate some research-ready data sets for researchers to access. Now, that's just the smartphone and wearable data, but then it will also be linked with NHS data from healthcare data custodians, and researchers will be able to access that linked data. Now, there's a number of ways that we can achieve this depending on where the person lives. In South Yorkshire, it will be with the South Yorkshire Integrated Care Board. In Yorkshire, probably the Yorkshire and Humber SDE, but nationally, it will be within SAIL. This is just some examples of healthcare data sets that we can link to, but as I've shown you from the consent process, pretty much we can link to anything that we have the ability to access, and as long as we can agree it with the data custodian. So I'm just going to finish by giving you an example project. This QR code takes you to an EOI form, so you can actually come up with a better idea. But just to kind of put some flesh on the bones, I'm going to give you an example project, and you'll be able to submit your own example projects using the form. So this is how we identify who has problems after a heart attack. And as a plain summary, over 100,000 people a year have this. If you have it, you're in hospital for 3 days, you get seen once a month later, and then you're left on your own, even though you've got a 40% chance of dying within 9 years. So this is a real problem. And we'd like to see whether data from phones and wearables can identify future problems before they happen. So if you apply to us or submit your EOI, it'll ask you what your research question would be, and this is a research question for this project. It will ask you what your inclusion-exclusion criteria are, and in this particular case, it will be anyone, but we will make sure we have 50% females. And for this pilot feasibility study, it will be 500 people. So this is the kind of project suggestion that you can submit using the QR code, and then we will look at these, get back to you with any queries, and prioritize recruitment of these groups so that we know when we have the data, and you know we'll have the data, so we know we can address important research questions once you apply to us for access to the data. So please do get in contact if you have any questions. This is the QR code to the expression of interest form. I'm just going to finish by thanking the huge number of people that supported everything. That's Jackie MacArthur and the British Heart Foundation Data Science Centre team, the PPIE group, been absolutely pivotal, the South Yorkshire Digital Health Hub, many colleagues on the call, the consortium members of Smart Health, who include Will, the Trust and Transparency team at HDR UK, and EPSRC, who allowed us to reallocate some of our funding from the Digital Health Hub to support this. So thank you so much. I think that takes me just about to time. I'm now going to stop sharing. It's a real pleasure to introduce Ellen Buckley. Ellen's been a postdoc with us for coming up for 2 years now within the Sheffield NIHR Biomedical Research Centre. Ellen has managed to achieve supremacy in not just clinical research, but engineering. She is an expert in writing ethics approvals while doing data analysis. It's just impressive, the level of skills. And she was a key part of some of the neurological sub-studies within the Mobilise-D Consortium. So thank you, Helen. That's very kind. So I'll pass on to Ellen, and then we can take your questions. Ellen's going to talk to us about wearable accelerometry and how that fits in clinical care. Thanks, Ellen.
Will, I think Tim did your job. Are you happy for me to start? Okay, cool. Hi, everybody. I'm Ellen Buckley. Let me just share my screen. Does this all show properly? No? Oh,
It's coming.
helps if I press the button, doesn't it?
Yeah, we can see that. Thanks.
Great. Okay. So yeah, hi, I'm Ellen Buckley. I'm a research associate here in Sheffield. I work with Tim at the South Yorkshire Digital Health Hub and the Sheffield Biomedical Research Centre. Much of my research is around sensors and smart devices, and particularly for mobility monitoring in the real world. So sort of relevant to what Tim's just been saying, but sort of more in the, we've been doing more work in the sort of research grade understanding of biomechanics in some clinical cohorts that could potentially be taken forward into clinical practice. So hopefully I can make that case as we talk through and how it's relevant to smartphones and other commercial wearables as well. So yeah, so I'm going to give a brief overview of some mobility monitoring studies we've done, and particularly talking about the work of the Mobilise Consortium. I won't be able to give a lot of results today, just given the time, but if anyone would like to go to this website here, there are a lot of publications already listed. The consortium mainly has finished now with some sort of extension work going on and some finishing up. So this will be where you could go to find out more information. So why measure mobility? So we know from previous research from probably the beginning of time how important mobility is. It obviously impacts our ability to move freely and easily around the world and adjust to our environments. And so some previous research of the consortium showed sort of gave us this conceptual framework where we see how important it is to people's sense of self and our ability to just interact with the world, as I say, and how important it is to their daily life. But it's impacted in almost half of disabled people. So in order to measure mobility, there are different ways that we can do this, either through questionnaire-based aspects of measuring mobility perception. There are mobility capacity tests, so supervised walking tests with a stopwatch would be an example of this. Whereas we think that mobility performance and what people do in their own environment could add a lot of extra additional information to the clinical picture of someone's condition and their lived experience of mobility disability. And so this is where having a sensor or a wearable that people could use in their home environment as a passive tool that was unobtrusive could allow us some remote monitoring to be done. And as I say, it can be then flexible. It's an objective measurement that could be more sensitive to subtle changes and complement existing clinical outcomes, and also support self-management. And it also reduce unnecessary travel to clinical centres. So if somebody's condition was stable, they wouldn't need to necessarily attend if they'd already conducted a remote measurement potentially, or you could identify people who did need to have more intervention or potentially a treatment change. So I'm going to give some examples today from some work in multiple sclerosis. This is a sort of prime example of where this kind of approach can be used. It's one of the largest causes of disability in working age people. It's an autoimmune mediated disease where inflammatory lesions then cause various different symptoms in different people. So you can see from this graph here, 48.9% are experiencing walking difficulty, but there's also bladder and bowel involvement, vision problems, dizziness, cognition, and fatigue is a big impact in people's lives. But how we measure that isn't always clear. And so this graph here sort of shows the existing clinical outcomes, such as the EDSS, are very good at predicting clinical changes, particularly in mobility, that have already happened, but it's not very sensitive to change. And there's a lot of underlying worsening that's currently being recognized by the field, where it's those detecting that could help clinical trials have a more sensitive endpoint to worsening over time. And so this is where we think that mobility performance and digital mobility outcomes could come in handy. So previous data has shown that we can already differentiate people in a supervised setting. So this is from a 6-minute walk test. Healthy people from MS and with more disease severity, that has an impact on the mobility outcomes in that people walk more slowly and less regularly. But clinical trials aren't quite there yet. So only 25% of clinical trials in this recent review included a mobility outcome. And when mobility outcomes are used, they're generally through a stopwatch estimation of gait speed, 10-meter walk test, time, how long it takes, or from a daily step count from something like a wrist worn. And so we think that at least the Mobilise mission was that we could do better than that. And so this is a big consortium effort to look at the technical and clinical validity and acceptability and usability, looking towards regulatory approval of these digital mobility outcomes. So as I say, the measurement that we've been taking forward is a single lumbar lower back worn sensor that people can wear for multiple days. The signals could then be analysed with robust algorithms to detect changes, turns, even transitions, walking bouts and gait events. And then this can give us information about people's gait quality and walking activity. And so in Mobilise, what we did is, as I say, we focused on these 3 different aspects. And so we conducted a technical validation study of people with different 5 different mobility impacts, hip fracture, Parkinson's disease, MS, congestive heart failure, and COPD. And then we also did a clinical validation study in 4 of those cohorts. And so this was a really large data set that we've captured across laboratory, clinic, and home settings, including a very comprehensive clinical assessment. And so these are some of the sort of key points that we've managed to, or we've aimed to determine. So what's the best sensor location? Ultimately, the consensus was the lower back would give us accurate data and trunk information as well. And so some of this is already ongoing, but we have got evidence that people are happy to wear these devices, and we have good data that we've captured that can sort of answer some of these clinical validity questions. So for people with MS, the key question then is, where we think these could give more information, is are they avoiding long walking bouts outside? And that would be then picked up through a lower level of walking activity. And so maybe they're doing less moving with purpose and lower, so that might be picked up through their lower maximum cadence, for instance. And so potentially we can then use these to detect changes in people who have progressed, to then see if there are changes in people who went on to progress. But obviously everything comes with a benefit burden kind of balance, and so we need to balance what patients will use and where, and what data do we need. So obviously for MS, this is a gait impairment, a condition where there is a gait impairment, so having that detailed gait analysis is really valuable. But we don't get a real-time insight. There's no continuous, like, long-term use in the so for more than maybe 1 to 2 weeks is kind of the maximum that I think we've really tested it in. So, and again with 6 monthly intervals, but if we had something that people could use more long-term, so that's where a smartphone or a wrist-worn wearable that people could wear more continuously might come into it. But obviously all of this data is very messy and heterogeneous, and it only gets more so when we don't know what people are doing. But in theory, this whole pipeline of sensor to DMO, we could potentially switch out for a device that people already own, a wrist one, a wearable. There's, you've got inertial sensors within your phone that could potentially extract the same information, but the context of that, and there's lots of technical questions about making sure that that's accurate, and yeah, basically I'll come back to my table in a second, but it does give us also a chance to add some context. So are people indoors or outside? What's the weather doing during the time that they're doing the mobility assessments? Are they using a walking aid? And so here, and we can map with the use of GPS here in Sheffield, we have tools to map the GPS to open source information about terrain and the weather. And so if you can see here, this is an example of an app that's been used in the group. And so you can see the cycling along one of the roads in Sheffield and different bouts of activity that are being picked up. But on the sort of back end, you can see that we're picking up stay points and waypoints where people have stopped. And then the journeys between those, we can then pick up how frequently people are going to the same place, but see differences between indoor environments and outdoor, like parks, or whether they're in a city centre. Is it somewhere they often go, or just every now and again? Are they traveling with people? How are they traveling? But there's questions then about noise in buildings, and also having to map what the GPS says to the actual world and where we know that roads actually are. So obviously here they were not walking through a building. There's a job to realign that with the actual world. And so yeah, back to the table, here we go. There's then obviously questions about how valid those third-party data sets and algorithms, so the step count from a phone, potentially that's less accurate than what we can gather from the lower back. GPS is very sensitive, so we need to consider how secure that data needs to be stored, and we do lose those features of potentially the upper body, but it does offer people the chance to use devices that they already own without the need for research devices. And so this is just to finish on the vision of where we see this kind of going and what we're taking forward into future projects, such as in the future, is a combination of both the sensor-based mobility outcomes and the phone-based contextual factors, which combined with other data sets could then contribute to an AI model of someone's disease progression over time. And hopefully give us lots of information about how people are progressing and their lived experience of their mobility disabilities. As I said, there's lots of papers already published, more to come. The data sets and the algorithms are already available online for the technical validation study work. But yeah, as I say, it's been a big effort, and I've been a small cog in the wheel of just on the data collection side. So thank you very much to participants, funders, and collaborators.
So thank you very much, Ellen. Thank you to Tim. Brilliant, brilliant talks, and covered a lot of ground. What we're going to move on to now is an update of one of the 2 driver projects, trying to do that difficult thing that Tim described of how you join together the data from patient-generated data with other data sources such as health records. And I'm going to invite Shui to present about the physical activity patterns after knee arthroplasty or Paprika study. Thanks, Shui.
All right, thank you, Will. Let me share my screen and set up my slides. Can you see my slides?
Yep.
All right. Hello, everyone. My name is Shui Shaw, a research associate at the University of Manchester. Today, I will provide a brief update on the Paprika driver project, highlighting key milestone, challenge, and next step. So we started the project back in January 2024 and received the ASIC approval in May, followed by NGR approval in September 2024. Right now, we are at stage 5. This stage includes collaborating with our PPI group to run workshops and gather feedback, working with RADA-based team at King's College London to build our recruitment system, setting up a data sharing agreement between the University of Manchester, King's College London, and the National Joint Registry. And finally, we're conducting internal testing to ensure everything functions smoothly. Now, if you joined our previous Paprika update session, you might be thinking, why are we still at this stage? Honestly, I had the same question, but we've learned a lot during this process, and these lessons are exactly what I will be sharing with you today. So you may want to know, what is Paprika? We co-developed a short explainer video with our PPI group. Let's see the video first.
Arthritis of the knee affects over 1 in 5 people aged 50 and above. It's a painful disease that can severely reduce mobility and worsen quality of life. Knee replacement surgery is a life-changing option for some, improving pain and activity.
It's painful for me to go up and down a flight of stairs, particularly going down, and I don't seem to be able to get across the road quickly enough if I need to. How much will my mobility improve after surgery?
Did you know that the data from your smartphone or wearable device could help to answer questions like this?
Hello, my name's Will Dixon. I'm a professor at the University of Manchester and a hospital doctor looking after people with arthritis. At the university, I work as an epidemiologist, studying diseases like arthritis and their treatments in populations. In the UK, the National Joint Register holds knee surgery information for everyone who's had an operation in the last 20 years. This is available to researchers like me, but the register doesn't collect information on physical activity, so we cannot work out how much better people's activity gets using that data alone. However, many people who have already had a knee replacement owned a smartphone or fitness tracker at the time of their surgery, which will have tracked their step count before and after.
Our research team will connect your personal data with the National Joint Register so we can tell future knee replacement surgery patients how much mobility they will get back after surgery.
If you join this study, you'll be helping me and the other 100,000 people who undergo knee replacement surgery in the UK every year. Please join this study today.
So this video breaks down the study in plain language, explaining what we are doing, why it matters, and how people can get involved. Our PPI partner played an essential role in shaping our study material. They provide valuable feedback on how the public might interpret key concepts, ensuring our communications are clear and participant-friendly. One good example is how we changed the title of eligibility section to "Check you can take part." It's a small wording change, but it makes a big difference in understanding the context, encouraging people to engage and feel included. We are collaborating with King's College London to develop a recruitment system using RADA-based platform. From our website, participants will be able to review the study information and documents. Then, if eligible, they can click a button to join the study. After joining the study, participants will be asked to complete a few tasks. These including 3 essential steps, providing information about their knee replacement, entering some personal details, and connecting their wearable device to allow data sharing. There's also one optional task which gives participants the opportunity to provide feedback on their experience of joining the study. When participants reach the device connection page, they will be guided with clear step-by-step instructions to help them share their data. Our goal is to make the onboarding process as smooth and intuitive as possible, while still ensuring our we meet all the necessary research and governance requirements. Before going live, we run comprehensive internal testing of full study flow, and this helped uncover several issues that we are now actively addressing. One challenge involves Apple Health. In order to get the Apple Health data from our participants, it requires linking through a separate HealthKit app. We are working closely with KCL team to develop this Apple app to simplify the data collection process. However, if a participant's data is too large, it may not upload in one go. Instead, it gets stored in cache rather than being sent to the server. So we are improving the system to increase the throughput and ensure retry mechanisms are in place for reliable uploads. Second is Fitbit issue. Fitbit's intraday data requires special approval to access. If you plan to explore this data in detail, it's worth to preparing those approval in advance. We also got challenged with data transfer latency and empty intraday data. During our first round of testing, it took nearly 4 weeks to receive the complete set of Fitbit data. The KCL team is actively working to reduce this delay, but even with improvements, we may still experience a 1 or 2 week data latency. Another issue is handling empty intraday data. Fitbit will return empty data if no intraday value are available for the requested time range. How to manage this intraday data in the right time range is still a challenge for us. This study has also been a learning process, not only for our research team, but also our collaborators at the National Joint Registry. At this time, NGR is not just providing data, they are receiving data from us for the linkage. We're setting up a secure channel to transfer the wearable data to them, so it can be linked with the hospital records. This is a significant shift and shows how wearable data collected directly by patients can become a powerful tool in tracking recovery and informing future care. We are now ready to take next big step, participant recruitment, which is scheduled to begin in mid-July. This makes a major milestone for the Paprika project as we transition from building infrastructure to bringing people into the study. Our next update webinar, we will share lessons learned from recruitment and data management, along with practical insights into handling wearable data. Thank you for your time. We look forward to seeing you again at our next Paprika project update session. Thank you. Hand back to you, Will.
Thanks very much, Shui. I'm just going to end with the last couple of slides, which are announcements. The first is about the next webinar. So this is held on the 3rd of September. It's going to be co-hosted with Sprite, which is a network around security, privacy, identity, trust, engagement, and Network Plus. The topic of the webinar is about cybersecurity. Interestingly, when we submitted the Health Research from Home grant application, one of the strong bits of feedback we had was about how are we considering cybersecurity. This is one of the ways. So we're going to try and share with the community why this matters and what you can do about it. We had to reschedule a webinar from last time, and this is now rescheduled for the 1st of October from the Transformational Prevention Unit at Novo Nordisk. This should be an excellent webinar, so please do book on for that. Our calendar of events, we've got a grant writing retreat that's happening next week. This is the first one that we've done. It's a little late now to sign up for that, but we will be hosting another one next year. We held our first annual event at Google in London in February 2025, so earlier this year, and we're just fixing the date for the next annual event, which is likely to be in February of next year, and we're putting together the program. One of the topics that we are likely to cover is something that came up, which is about how do you handle GPS data. I know there were questions about that we didn't really get to, but we've got experts lined up to come and talk about that at the annual event, amongst many other topics. And then lastly, we've recently held our first annual analysis challenge or hackathon. And again, there will be one lined up for next year. The webinars run every 2 months. So you've got one in September, an extra one in October, and then there's one in about sleep in November. And the final slide is resources where you can learn more about health research from home. There's a GitHub page, a website, LinkedIn, and via these resources you can sign up for our newsletter and get updates about everything that's happening. So a summary of what I've talked about. Finally, there's a poll coming, and we'd really like your input as to what you'd like to hear about in future webinars. So please do hang on and give us a bit of feedback about what you would like to hear. And I think the final thing to say is that one of the questions was suggestions for health conditions to Tim. He's probably putting an answer in, but we'll share resources afterwards. We'll send out a link to the recorded webinar and where that's hosted. And we'll also collect any information from Tim and Ellen, such as how you can take part and suggest health conditions for their study. So thank you again, Tim. Thank you, Ellen. Thank you, Shui. Really wonderful presentations. Thank you all for coming along. Do actively take part in health research from home. It's a partnership grant designed for the whole community. If you have ideas of things that we should do or change, please do get in touch, and we hope to see you again. Thank you very much.